Hi, this is Junaid with Acute Ischemic Stroke 2019 Guideline Review. We're about to finish about the section number 3 in which we discussed emergency supportive care and emergency treatment. We discussed IVtPA, mechanical thrombectomy, and we're going to basically, tie up some loose ends in this particular lecture. We're going to discuss what to do in the first 24 hours and what not to do within the first 24 to 48 hours. So the first and foremost is use of antiplatelets. Those patients who got IVtPA or mechanical thrombectomy within the first 24 to 48 hours start aspirin. Period. Level of evidence A, class of recommendation 1. No questions asked. This is a newer recommendation. If you have a patient who did not get TPA, mainly mild non-disabling strokes, in those patients, you should actually start patients on dual antiplatelet therapy, aspirin and Plavix, rather than just aspirin. And within 24 hours, you should start it. What the data has shown is that it decreases the risk of early neurological decline, and you should consider in basically all patients that you haven't given TPA. So in those cases which are milder, let me clarify that. It doesn't have to be that if the patient actually has, NIH stroke scale of 6 or above, or can potentially bleed into their brain, do not do that. In mild non-disabling strokes, potentially, what you have to do is do aspirin and Plavix. Guidelines are very specific that we do not know when or how to use IV GB2B/3A inhibitors in these cases. It is a moderate, weaker recommendation. It is not a moderate recommendation. It's a weaker recommendation that we really don't know the data and when to use this. The only time I have used these agents is that if I have to do an acute stenting and I cannot do because there's a small bleed in the brain after the intervention in tandem occlusion cases, and I cannot do a full load of aspirin and Plavix because I don't know if that bleed can go worse, I've used these agents. In those and only those specific cases, I have personally used it. But in a regular sense of the word, given the neurointensive care physician that I am, I have never used these agents. So in short, this is not a recommendation. It is that we don't have enough data and it is uncertain. So when you have to use them, then you have to use them, but it is not something that you use them on a regular basis. And clearly do not use apixaban. And then aspirin is not recommended as a substitute for acute stroke treatment for IVtPA. I don't know why they have to say it, but apparently they do. So if there's still some confusion, aspirin is not an acute stroke treatment. TPA is, especially those who are eligible for it. Now, anticoagulation. The usefulness of urgent anticoagulation has not been defined. There's no reason that if you have a person who has atrial fibrillation that is coming in with stroke and it has not gotten a TPA or a mechanical thrombectomy, should you anticoagulate them right away? I generally don't. At least I get an MRI, I look at the stroke volume and then the bleeding risk, have a discussion with the family, and then consider anticoagulation depending on what we are. I also do get another, CT scan to make sure within 24 to 48 hours to make sure there's no, reperfusion injury, because sometimes there's autolysis of the clot and then the vessels open up, and then sometimes there is, at least petechial hemorrhages that do come in. Very important that people do confuse petechial hemorrhage with laminar necrosis. Laminar necrosis is not petechial hemorrhages. So therefore, you can still use anticoagulation on those patients. So timing of anticoagulation, especially urgency of it, is not well established. It is a weaker recommendation. Do you need to start within 24 to 48 hours? In some very minor strokes, in patients with AFib with the RVR, you clearly may consider using it. But if, for example, if the patient actually on the echocardiogram has a thrombus sitting there, you're going to start it, period. That's an absolute indication for it. So again, this leaves you for room to make your choices according to your patient's needs. Now, if there's a non-occlusive stroke or severely stenosis, and clearly most of the cases that we actually look at is severe basilar stenosis, what do you do? Should you use anticoagulation? The data is not there. It is a weaker recommendation to use anticoagulation. I personally do. If there's no significant DWI lesion in the posterior circulation, I will drop down the blood pressure and do anticoagulation. But there's a very tight line that we have to follow in terms of blood pressure management and anticoagulation, because I want to decrease the blood pressure goes to less than 180. And then first you start that, see if the patient is not decreasing or having any neurological deficit, is not hemodynamically significant neurological exam, and then you decrease the blood pressure and start anticoagulation. Again, these are very fine lines that we have to walk. Again, the guidelines are just stating that we don't have enough evidence. As you can see, it's all B and C, and the class of recommendations are all weak. So what you have to do is you have to make sure that you are not producing any harm to the patient, but you have to make sure that the benefit and the risk is actually properly evaluated. Same thing with using of dabigatran and all that within acute, first 24 hours. And same thing, if you want to use other low molecular weight, heparin, etc., to anticoagulate these patients. So urgent anticoagulation with the goal of preventing early recurrent stroke and halting neurological decline is not a good idea. So if you have a patient that is having crescendo decrescendo or TIA, then actually it's starting to get worse, and now you're actually having cerebral edema, and you're thinking you're going to start anticoagulation and that's going to help. No. What you are only doing to understand is with these anticoagulation is that you are managing the risk of an early recurrent stroke because of a known AFib with RVR, clot in the heart, etc., to the benefit that you're going to decrease a secondary stroke right away or early neurological decline secondary to repeated thrombotic event. You're not treating an acute ischemic stroke here. So that's why that clarification needs to be made in the guidelines. Now, all these things that we thought at some point in life are not helpful. Hemodilution, albumin, vasodilatory agents, and then, mechanically through intra-aortic balloon pump, improving blood flow to the brain. None of them work. They actually cause harm. Do not do it. Similarly, the agents that we all believe that are potentially neuroprotective. Like, for example, I personally think MAG is very protective in status epilepticus patients, subarachnoid hemorrhage patients. I may think so, but there's no scientific evidence. I do not do it. I personally think about it. I personally think that they should be given more money to be studied in a clinical trial, but I do not think that they belong in general clinical practice. I'm very grateful for your time. Thank you. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.